today's seminar. I think most of you know Dr. Matt Ferrari. Around the world and the campus, he's famous for two things. What's the first?
Lucy.
He's the bicyclist and Uber driver in chief for the acclaimed dog Lucy. She enjoys breezy bike rides. Yes, she does. I've seen trail runs. Yes, and sun-filled long naps. All right, awesome. The second is Matt is the director of the Center for Infectious Disease Dynamics here, and as a result, is a close partner and ally of the One Health Microbiome Center. We've spent the last year talking a lot about activities, some of which have been implemented, such as faculty searches together with common themes of interest. Some of our members here contributed to a workshop that Matt ran for the EEID Symposium, the Ecology Infectious Disease Symposium that was held here a few months ago. And there's more activity kind of in the background for strategic planning for the future. So Matt invited me to speak at the CIDD Center Seminar Series, which was yesterday, and we're reciprocating with him talking here today. In the hopes that we'll continue to build those kind of integrative aspects. Obviously, we're two centers that really think a lot about microbes, and we should be thinking about where the synergies are. So Matt's two focus areas of quantitative data analysis are on the incidence and distribution of diseases that are either endemic or that are erupting and sort of breaking out into countries. And then the other side of that is kind of looking at surveillance data and interventions sort of modulate those disease outbreaks and sort of are those interventions effective or not. And so today we're going to hear a little bit about the CIDD Center and then his research program. Please join me with a clap and welcoming here. And we give all of our internal speakers a kind award plaque with your name on it from the One Health Microbiome Center. So thanks for joining us. Yeah.
So thanks everybody. Thanks for the opportunity to speak and talk about CIDD. This is a funny thing. 3 days ago, I had like 15 minutes worth of content, and up through about 1 o'clock last night, I probably had about 3 or 4 hours of content. And every time you're asked to do something like this, to sort of look back and think back over your organization, what they do, what their mission is, how they develop, right? It's a wonderful time to sort of learn and reacquaint yourself with things you've done. And so what I'm going to try and do today is talk a little bit about the center and then a little bit about my research. And in both cases, I was sort of looking back over time, revisiting some old stuff, discovered some old things, found some old slides. And so it's been a fun experience for me in setting that up. So the tagline for CIDD, which dates back to our first CIDD director, Pete Hudson, and we've maintained through the 20 years that the center's been around. Center directors were Pete Hudson, Brian Grenfell, Mary Poss, Andrew Reed, Isa Catadori, Beth McGraw, and finally to me. So I'm telling you just about the most recent stuff that's going on in CIDD, and we have this long history that's been developed by all of them. But Pete started this with the idea of proteins to pandemics. And that was really what was sort of fascinating, is that to understand the biology of infectious disease and some of the critical challenges that we're dealing with, you need to look across all of those scales. And that's mathematics and statistical modeling has always been a common thread that ties us through there, right? None of us could have imagined how prophetic that tagline was going to be. In the 20 years that CIDD has been around, we have experienced multiple pandemics, starting from SARS-1 to H1N1 to Zika virus to Ebola, and then most recently SARS-2. And we've conducted research and operations and engagement and outreach at all those levels. And so this background, which I'll show a bunch of times, comes from the Huck Visual Arts team. They developed this for us for an interactive video display that's in the lobby of MSC. So I encourage you to come and check it out. What you can do is everywhere there's a little hand, you can put your hand on there and a video will pop up and it'll talk about some grad student research projects that are going on. So I'll talk mostly about faculty today, but come down to MSC and you can learn about what our graduate students are doing. So where did CIDD start from, and how did it develop over time? My perception, at least, and I think Seth made this point yesterday at CIDD as well, is that the historical view of microbiology and infectious disease biology itself started in the sort of individual disciplines of human medicine, veterinary medicine, and plant pathology, right? And they developed theories and methods and approaches that were within those individual silos. And I think the innovation of what brought CIDD together was to try and turn that around, because all those perspectives were focused on the host, on the disease that is generated, right? Trying to mitigate, remove, prevent that disease, but not studying the cool and exciting biology of the interaction between the pathogen and the host. And I think what CIDD has largely done is to try to take the pathogen's eye view and look at the host as both a resource, a resource, an environment, and an evolutionary challenge. And by taking that focus, right, we were actually able to bring scientists together across all of those disciplines and hopefully take all of those disciplines further, because we can borrow from across the terms, the learning, the experience, the methods across all of those individual groups. And so we've been trying to do that for quite a while. Since we focus on the journey, not the destination, I think it's I'm going to tell you a little bit about the questions that we ask and the people we ask those questions with. Importantly, we mostly start from the perspective of, so we're infectious disease, so we do think about sickness and illness and harm and virulence, right? So how do parasites make us sick, and why do parasites make us sick? To do that, we've always taken a dynamical view. Right, that's the D in infectious disease dynamics, one of the Ds. And by that, I mean not just describing where the system is now, but how and why it's changing. Where are systems going? How are pathogens moving around in the environment? How are they moving around in the host? Right? To understand how parasites make us sick, we need to understand the sequential processes of entering the body, evading the immune system, replicating, exiting the body, right? All of these have biological, mechanical challenges inherent in them, right? And by studying all those pieces and looking at all those pieces in series, we can identify bottlenecks, identify targets for treatments and therapies, try and figure out which will be the most effective and the most efficient, right? We're also really interested in this basic question of why it is that things make us sick, right? The old conventional wisdom, right, was that virulence, harm to the host, only arose at the beginning of an evolutionary relationship between hosts and pathogens. And that over time, parasites or microbes would always evolve to become avirulent, right? You would start over in my center and you would end up over here, right? But the long-term historical evidence and the long-term persistence of parasitic and virulent interactions between hosts and pathogens suggests there's at least two paths. Right? And of course, I'm sure as we can all appreciate, there's a large continuum of possible ways, right, that you can either benefit the host, harm the host, work together, sometimes do one or the other, right? And those are the set of questions that are exciting to us, right? That the modern concepts of the maintenance of virulence, generally speaking, come from a hypothesis that suggests that virulence or harm to the host is tightly linked with transmission. The mechanism, in order to transmit and get from host to host to increase your evolutionary success, you have to harm the host in order to do that, to acquire resources or facilitate getting out of the body, right? So that's one view that brings us to sort of a host level, population scale, transmission-based view of virulence. The other is that it's driven by intra-host competition among strains, right? To be the one that's at the highest relative abundance at the point of transmission, and that within host ecological competition for resources between pathogens and parasites is what drives virulence as a byproduct of trying to be at the highest numbers within them, right? And so many of the folks in CIDD have tended to focus on these individual points, right? And oftentimes then use those to target therapies, treatments, interventions, right? Either to prevent illness or prevent the evolution of virulence or mitigate the evolution of virulence. And then, of course, in every evolutionary question, right, there's all these other things that we've been fascinated, is that in between all of those things, the beautiful thing about pathogens and microbes is that they'll do anything. And why is it? How is it? There is so much variation maintained within the world with respect to the prevalence of disease, the virulence of pathogens, the transmission of pathogens, the tolerance of hosts to infection, right? How is it that the world has maintained this vast and exciting array of variability that's out there, right? So that's the questions that get us excited within the center, right? By the numbers, we are a center at Penn State, which is, as you guys all know, a center is a glorified club. We're a glorified club that's been around for quite a while. We've been around for about 20 years. At present, we have about 50 active labs within the group, and that comprises about a little bit more than 200 personnel. In 2021, I did an evaluation of all the existing funding of all the labs that would tell me within CIDD. Not everybody responded to that, but at that point in 2021, we had $111 million in active funding. Right now, a disclaimer that all these numbers were acquired through the Penn State systems, and they could be off by at least an order of magnitude. But right, we've been around for quite a long time, and many of our activities, many of our labs are quite mature, right? And in fact, we measure our impact and our activities, not just in terms of the local things we do, but also in terms of the leadership that we have at the global scale and the large international programs that we've been involved with. Over the course of our 20-year progression from our humble beginnings in Mueller Lab and ASI, and then our primary location now over in the Millennium Science Complex, we've done a lot of small and local things. We have weekly discussions on Monday. We have a weekly seminar series on Thursdays. We've tended to fund collaborative workshops to try and develop large-scale grants and papers. And we've also contributed to leading large-scale international research and training programs, starting with things like the Vaccine Modeling Initiative that was funded by the Gates Foundation, starting in about 2010. The Research and Policy for Infectious Disease Dynamics Initiative of the Department of Homeland Security, which ran for about 10 years and was focused on foreign animal diseases and zoonotic emergence. It led to the training of a huge number of graduate students and postdocs, including the current director of the Center for Forecasting and Outbreak Analytics at the CDC, which is the new effort for pandemic prediction at the CDC. The Vaccine Impact Modeling Consortium and the Malaria Modeling Consortium, which are current large-scale multi-institution collaborative projects that are designed to take scientific understanding and mathematical modeling and directly infuse those into policy. And both of those are supported by the Gates Foundation currently, and the outputs of that are used and digested by World Health Organization, US CDC, Gavi, the Alliance for Vaccines, and the Gates Foundation to help drive some of their funding and support for vaccines and therapeutics. And then every 10 years, we have a really big party. We invite all of our friends over. We hosted the 20th anniversary of the EEID meeting this year. It began here at Penn State in 2003 with Pete Hudson's 50th birthday. And again, has been a central point for bringing faculty and students together from all around the world to talk about the ecology and evolution of infectious disease. Through this, we have developed graduate training programs that for a long time were the primary focus of disseminating quantitative training in ecology and evolution of infectious disease. Many of the materials that were developed through that program are now actually integrated within the classes and courses where our trainees are now 10 years down the road, faculty members and deans, and have incorporated this into standard sort of bricks and mortar programs. There are a ton of folks, and I can't possibly identify everybody that's in CIDD, again, because of the Penn State system and my and how hard it is to update websites. But we do have a variety of core areas of strength. We have lots of individual folks doing cool individual things, but we have a handful of clusters, right? Starting in virology, we have particular strength in vector-borne disease, both arboviruses and malaria, and parasitology, broadly speaking. Real strength in zoonotic emergence and emerging infectious disease, as well as the evolution of virulence and the evolution of resistance. And central to all of that has been our central and core strength, which has been in mathematical and statistical modeling. And so that has always been the sort of central hub that has helped us to connect many of the empirical labs within CIDD, right? And help to facilitate collaboration, right? And also, because I'm one of the people that's in there, it also allows us to tackle some of the larger global scale challenging problems that arise either from purely observational data or systems that are too large to be addressed through experimental systems, and allows us to sort of amplify our impact. So the kind of large scale global models that I get involved with, right, can't possibly be done at the lab scale, right? But all the contribution of the science and the learning that comes from that lab level, we can integrate up through large scale mathematical models. Okay. We can, again, coming back to this protein to pandemic scale, we can think about the various of the folks that we have here that are doing fun and exciting research. So I'm just going to pick off a handful of folks that have been doing cool stuff quite recently. So Joyce Joes, who's just received 3 separate NIH grants just in this last year to study the molecular interactions between arthropod-borne flaviviruses and alphaviruses and their hosts and host cells. These includes things like Zika virus, and she's looking at the mechanisms of maternal to fetal transfer in Zika virus. Powassan virus, which is an enormously scary emerging flavivirus that's transmitted through ticks that we're finding here in Pennsylvania, trying to understand the basic biology of how that establishes and enters and exits the cell to try and identify targets for drugs and therapies, right? As well as things like chikungunya and some of the other emerging arboviruses around the world. Troy Sutton, who has moved from the basics of viral structure and viral behavior to transmission, right? Troy's been working on the other pandemic that's been bubbling in the background that not as many people have been paying attention to, but this is H5N1 high path avian influenza. Maybe in this building, a lot of people are paying attention to H5N1. I forgot where I was going to be. Sorry. Right. So this has been circulating in bird populations globally and has caused a handful of human mortalities and a number of quite scary outbreaks in wild mammals. Currently, H5N1 can infect and cause harm in humans, but it can't transmit in humans, and it can transmit only weakly in a handful of mammal species. And so what Troy and his lab have been doing is working in the BSL-3+ facility out at the Pell lab to try and develop standard assays for looking at the transmissibility of these high path avian influenzas, trying to come up with standard ways of talking about not just the disease it will cause, but the pandemic potential, the potential for it to transmit and spread within populations. They've been doing this in the ferret model, which is the gold standard model for flu in human populations. And to the extent that they can now come up with an assay and a measure for transmissibility, right, they can then correlate that with specific molecular biology and viral structure, the kinds of elements of things that Joyce has been working on, and now we can tie that to an important phenomenon or phenotypic outcome of transmission. Sagan Friant and Attar Bjornstad just recently received a $4 million grant from the EEID program, that's the NSF NIH program, to study the risk of spillover of Lassa fever virus from rodents to humans in Nigeria. This is a large collaboration with Penn State, Tulane, Zoological Society of London, and the African Center of Excellence for Genomics of Infectious Diseases. And they're specifically focusing on human interactions and human behaviors, how human land use and human behavior and cultural practice interacts with the landscape and either mitigates or mediates the risk of exposure and interaction with rodents and potentially loss of people. Pete Hudson, who is the first director of CIDD, is one of the coordinators of the Bat1 Health program. This is a large-scale program funded by the Defense Threat Reduction Agency. I don't know if any of you have ever worked with them. I strongly really recommend it. They've got a lot of money and also a lot of bureaucracy. But this, again, is a multinational organization that is focused on some of the major components about the emergence of infectious diseases from bats, trying to understand the basic biology of bats. Why is it that bats have so many pathogens, so many viruses that can cause harm, but themselves manage to tolerate those infections, right? And so they're a reservoir of viral diversity that can potentially cause harm to humans, right? What are the drivers of the interaction between humans and bats that can lead to emergence and spillover? How can we predict and identify where those things are likely to happen? Where should we be monitoring, right? And they're also going all the way forward to trying to identify what are the landscape changes, what are the steps we can take at the landscape and conservation scale to mitigate that risk and try and prevent that potential emergence. Right? Kurt Vandegrift, along with Pete Hudson, just received a $4.5 million USDA grant. Early on, largely from Kurt's 20 years of experience of sampling wild mammals in and around Pennsylvania, right? Penn State was one of the first places to help document the spillover of SARS-CoV-2 from humans into wildlife, and particularly into white-tailed deer. And as we saw that and started looking more and more of the mammals we started looking, and we started to find SARS-CoV-2, right? And so Kurt now is leading this project to sample 58 different mammal species all around North America, with the idea of trying to understand where SARS-CoV-2 is, which animals are maintaining this, and what is the potential for spill back into human populations, and what is the potential for the maintenance of viral diversity across these potential reservoirs, right? Not so much that they'll necessarily be a driving force of frequent outbreaks, but they could be a potential reservoir of viral diversity that could give rise to new variants that then themselves might cause harm in humans in the future, right? Nita Barty is going to be leading a $2.3 million initiative through NIH and NSF to study the role of social and cultural factors such as human movement, built infrastructure, and access to healthcare in driving the predictability of measles and Ebola in Democratic Republic of Congo. This is a collaboration with the Ministry of Health in DRC and Médecins Sans Frontières France and Epicentre, their research. And just yesterday, in a paper that just came out in Nature Medicine, Maciek Boni and folks from his lab, is the paper that was led by Robert Zupko, had been working with the Rwanda's National Malaria Control Program to develop strategies for combination therapies to combat artemisinin-resistant malaria in Africa. Artemisinin-resistant malaria was first documented in Africa in August of 2020. Right? And it was first documented in Rwanda. And so the Rwanda control program has been rapidly working on strategies to change the application of combination drug therapies. Maciek has experience from working on combination therapies when he was the director of a program at an Oxford program in Vietnam. And they've been looking at what are the appropriate rollout strategies and combinations to try and mitigate the spread of resistance alleles. And of course, many of us across CIDD shifted our research and our outreach to the COVID-19 pandemic over the last several years. This ranged from really basic work that Ganesh Anand was doing in the structure of the spike protein and the structure and binding affinity of the spike protein. Mariah Sparra led a very practical and applied initiative on hygiene and disinfection of lab materials and masks. We had a number of folks working on trying to predict the developing epidemiology and persistence of SARS-CoV-2. Many of us got involved both at the local university and state level in developing public health recommendations. I was involved both at the level of advising CIDD, the local school district, as well as advising the entire Penn State University system. Andrew Reed developed a wastewater surveillance system that is still running across Penn State. Maciek and Ephraim Hanks from the statistics department worked with a number of state ministries of health, state departments of health across the Northeast to track trends and make predictions to try to address hospital staffing and vaccine procurement. Thankfully, most of us have been able to scale those efforts back, and we don't do that all so much. But one of these, the COVID-19 scenario modeling hub, has been enormously successful and still contributes to U.S. national COVID, influenza, and RSV planning. So Kat Shea in the biology department is one of the founding organizers of the scenario modeling hub, which is now run out of UNC Chapel Hill. And this brings together modeling groups from all across the country and all across the world to work with government, state, and industry stakeholders to develop scenarios about what the future might hold for COVID, and then process them through the mathematical models that all these groups are developing and look for predictable and generalizable patterns about what the future might hold that can then be used to guide investment, planning, policy, education, and training. So this has been enormously helpful. It's been they've developed reports and products that have been integrated into discussions at the White House, at the CDC, and the FDA that affect things like the rollout of vaccines, the messaging associated with vaccines, and the targeting of vaccine. Who is eligible to receive vaccines at any given point. So from really small up to really, really big, right? And we have all of these folks that are working together, and mostly our goal is to facilitate them talking together, right? And what we've developed over the course of the last 20 years, right, is this base of expertise that allows us also to export this out to the rest of the world, and use our center as a hub to coordinate much larger groups at the national and international scale. All right. Pause there. I've always thought I was an unlikely director and an unlikely spokesman. I'm not a very outgoing or loud person by my very nature. My guiding philosophy in life has been to speak softly and wear loud shoes. But because I have been here at Penn State as long as Sid has, I started here at Penn State in 2002, doing my PhD. I got to watch Sid develop. I got to watch the progression of Sid through the variety of different directives that we've had. Over that time, I have myself worked on all of the three silos. I started working in plant pathology on viral and bacterial diseases of squash. I have current projects right now working on the control and monitoring for foot and mouth disease in livestock. We're working with the Indian government on strategies for elimination, for rollout of vaccination and elimination of foot and mouth disease in India. And I've spent the vast majority of my career and the vast majority of my time focused on a singular problem that a lot of folks around here don't always remember. Again, maybe folks in this room do, but a lot of folks out in the public don't. So I've been again sort of obsessively focused on measles. Walt Ornstein, who is been the director of the Emory Vaccine Center and was the director of the U.S. vaccination program during the time of the elimination of measles. Refers to measles as the virus that we love to hate, right? And I've stolen that and repackaged that statement of his because unfortunately, measles is the virus that I hate to love. I struggle with the fact that I love the science. I love the biology of measles. I'm desperate to get rid of it. And I would like it to be, my goal is that all of that exciting science will be relegated to history books at some point. But I can't get over the fact that I find it exciting and fascinating. And I've been criticized many times for smiling while I talk about measles. Measles is a concern worldwide. It's a morbillivirus. It's enormously transmissible. It can lead to really severe outcomes in young children. In under-resourced areas, it can result in death of 1 to 5% of children that are infected. Despite enormous efforts to vaccinate against this disease, one of the things that's fascinating about this is that the virus is very stable, the vaccine is very stable. We've had it for over 50 years. Despite that, measles still persists in the world. Still results in over 100,000 deaths in children under 5 every year. It's an interesting virus and it's an important virus from a global health perspective, even though as the mortality associated with measles has diminished, right? The headroom, the potential for that mortality to increase if vaccine programs are relaxed is enormous. So measles cases averted, the number of deaths that are prevented each year due to measles is the largest single contributor to the immunization agenda 2030. Right, so that's WHO's large-scale planning agenda over the next 25 years. Right, it's not the number of deaths, not the number of deaths that are happening, but the number of deaths that could happen if we back off our level of control against measles. Again, it's fascinating because it's so stable. It has a really wonderful and elegant biology. It's transmitted through respiratory droplets. It's enormously stable. It's stable for the short term in those droplets, and can persist in a room for an hour or two. It hijacks the very cells in our body that are designed to look for and patrol against invading threats. It disproportionately enters the body through things like dendritic cells. And so the cells that are supposed to protect us from the outside world, they're what measles targets. It moves from there into the respiratory epithelium, right? Binds to receptors on the backside of respiratory epithelia, and then buds out of the front side of respiratory epithelia where those receptors don't exist, right? And so it releases itself into the lumen of the respiratory system and then is really efficient at getting out. Because unlike things like flu, which bind to a general receptor like sialic acid, right? A lot of flu that gets produced actually gets bound back to your respiratory system. It doesn't always get out of you, right? Measles measles is put into, has a highway to get out of you, and it's enormously transmissible, right? So on average, one person with measles might then give rise to 20 subsequent cases, using the sort of classic terms that we discussed. The high transmission rate and the fast kinetics of measles transmission. Infection lasts about 2 weeks. Transmission can begin in the pre-symptomatic phase, something like COVID, right, where you can start transmitting even before you have symptoms of rash and fever. That means that no matter where you are in the world, measles tends to burn hot. It has these really high boom-bust dynamics, these really dramatic outbreak cycles that can vary over orders of magnitude, even within a year in endemic settings, right? And so these are just I was digging through my hard drive looking for measles time series from places that I've worked in the world over the last number of years, right? And everywhere you see, right, there's some variability in the peaks, but always, right, large scale, highly replicable variability, right? And again, from a dynamical systems perspective, that's enormously fascinating. This is probably the most overstudied time series in the whole world. This is the time series of measles cases in London, England, in the pre-vaccine era from 1945 to 1965. Huge amounts of biology have been based on this one single time series. Brian Grenfell won the Kyoto Prize for his analysis of this and the science that arose from that. that natural tendency to boom and bust cycles, plus the interaction with humans' natural tendency to do things in cycles throughout the year, right? We're pretty regular organisms, right? And that regularity that we generate interacts with the natural boom and bust tendency of measles to create these regular cycles. This was well recognized in work by Paul Fine initially, and then Ottar Bjornstad, who's currently here at Penn State, and Brian Grenfell, who was a former director of CIDD. And they showed this regular pattern of measles outbreaks that was timed with school terms. When kids came into school at the beginning of the year, they would all come together. You get lots of interaction, lots of transmission, lots of respiratory droplets that would fuel these massive outbreaks that would then be self-limiting because measles produces a really strong immune response. They'd be self-limiting and end, right? But because it moves so fast and immunizes so many individuals, right? It would then take time for those susceptible individuals to build back up and create enough fuel to generate a subsequent outbreak, right? And so the timing and regularity of those peaks depends on the birth rate and how fast individuals are being added to the system, right? In the several years after World War II, when there were lots of babies being born, that rate of influx into the system was enormously high, and there was enough fuel, enough individuals born into the system in between years to produce annual outbreaks, right? As couples got bored with each other over time, the birth rates dropped, and those outbreaks then became every 2 years because the first outbreak was so large, it would burn through so many of the susceptibles. There wouldn't be enough, there'd be so much population immunity. It would take 2 years to build up enough susceptible kids to fuel that next outbreak, right? Highly regular, highly repeatable. We study that with a really elegant set of nonlinear equations called the SIR model that I won't go into great detail with. But when we looked at the dynamics of measles incidence in Niger and other countries in the Sahel and Western Africa, we saw patterns that were both familiar and fundamentally different. We saw the same boom and bust cycles. This is a time series from Niamey, the capital city in Niger. And then we found that even in the largest cities, measles was frequently absent, in fact, right? It was really extreme variation that we were seeing, right? But at the country and regional level, it was highly persistent and oftentimes devastatingly so, leading to large outbreaks that could affect tens of thousands of individuals, leading to thousands of deaths. It's probably worth commenting on how I, a 28-year-old white ecologist in Pennsylvania, started working on the dynamics of measles in Niger. How I got started doing that was the way that all great stories begin. I answered the phone one day at the wrong time. And this was a sort of foundational in my approach to things and the development of some of this science. But a woman by the name of Rebecca Grace, who is now the director of the Pasteur Lab Network around the world in Paris. She's an American epidemiologist and now a long-term friend of mine. She was looking for someone to help understand and make models of measles outbreaks, particularly because she wanted to use those models to explore the impact of vaccine-based interventions. She was working for Epicentre, which is the research arm of Médecins Sans Frontières France, right? And so Médecins Sans Frontières is a crisis and disaster response organization. One of the kinds of crises they respond to around the world are outbreaks of infectious disease. Epicentre is the research side. They actually do a lot of post hoc processing and MSF activities, trying to figure out what worked and what didn't, right? And MSF was engaged at that time in a process of advocacy for the use of vaccination in response to measles outbreaks. That might sound like a funny thing to think of. Well, we got measles, it's vaccine preventable disease, if there's an outbreak, we should vaccinate everybody, right? But at the time, this was in 2004, the WHO global guidance for outbreak response for measles vaccination was contraindicated at the population level. We vaccinate individuals, and in fact, we oftentimes do post-exposure vaccination to try and minimize the severity of disease. But at the population level intervention with vaccination was contraindicated. The reason being was that it takes time. You have to detect the outbreak. By the time you detect the outbreak, it's already moving fast. Right? Then you have to bring vaccine in. You have to mount a response. You have to take doctors and nurses, give them needles and vaccines in cold chains and get them out into the community. And that whole process takes time. And the concern was that the opportunity cost of that large-scale response would take resources away from clinical care, away from treating kids that were infected and had disease. Right? And so this was a cost-benefit decision. It wasn't a criticism of the value of vaccination per se, or the protection afforded by vaccination. Right? It was a statement that in that moment, right, the cost of vaccination wasn't worth the potential of delaying or reducing the provision of clinical care. In a series of papers, what we did was to develop some mathematical models where we fit models to the time series of an observed measles outbreak with an observed MSF vaccine-based intervention. MSF worked with the Ministry of Health of Niger to do a vaccine-based intervention during an outbreak in Niamey in 2003, 2004. They started that intervention, and what we did is we looked at what the rate of decline in measles cases was after that intervention, right? And then what we had to do was we couldn't create a true control where we then took the exact same city and let a measles outbreak run through it. There's some ethical challenges there, right? What we had to do was to use a mathematical model to create an in silico control, right? And look at what the possible outcome might have been had they not done that intervention. So we made a model and took the vaccine out of it, right? And what we did was we ran that and we looked at what actually happened, which was a relatively small potential benefit that we calculated. We figured that MSF managed to avert about 11% of cases. It was a big outbreak. 11% of cases is a good thing, right? But what we found, what we suggested was that if the policy existed, if you didn't have this policy barrier that said you shouldn't vaccinate, if you could actually plan in advance and pre-position vaccine in places where you knew outbreaks were prone, and you could detect and respond quickly with vaccination, if you could have started the response here, then you would have had a much, much bigger impact, right? And so it was in fact the WHO language and the WHO policy guidance that was one of the biggest barriers here, right? And again, through a series of papers and advocacy by MSF, they managed to change that policy in 2004. Right? And it was that experience with MSF and then the direct engagement with the Ministry of Health in Niger that we then did a bunch of subsequent science and gave us the opportunity to do a bunch of nerdy stuff after we started with that specific engagement. And so what we did was we took that mathematics and we looked at whether or not we could push on it. If we made that math match up to the birth rates that we saw in Niger and the seasonal fluctuations that we saw in Niger, is it possible that the same simple set of equations can give rise to this dynamic and this dynamic? Right? And what we found was it did. That if you change the seasonality, the difference between the transmission rate in the high season and the low season, and if you change the birth rate from the low birth rate that was in London in the 1950s and 1960s to the high birth rate in Niger. Niger has one of the highest recorded birth rates in the world, right? You push this dynamic from these regular biennial cycles every 2 years, right, up into a regime where you get these complicated multi-annual cycles, 4 and 8 years, and in fact, the potential for deterministic chaos, right? Are there any nonlinear dynamicists in the room? Yeah, right? This is for you, Hide, right? We love chaos, right? Like showing that chaos exists in the natural world has been like the holy grail of mathematical biologists for a long time, right? And so for us to show that we could actually identify in the real world a place where the conditions were sufficient, at least, to generate the dynamics of nonlinear chaos is really important because that affects the degree of variability that we expect to see, right? From year to year, right? It's less regular, higher variability, more important in pre-positioning activities in public health to be able to respond to that variability. It's hard to predict far out, but you can overcome that because you have short-term predictability, and so long as you pre-position resources, you can try to address that. My role in that was mostly as a mathematician, and I wasn't directly focused on the mechanism associated with that. But Nita Barty is through collaboration with Nita Barty, she contributed to trying to understand what the underlying mechanism was. What we all noted was that measles cases were very strongly correlated but shifted with the rainy and dry season. There's a single rainy and dry season in Niger and in most of the Sahel. When it's dry, it's very dry. When it's rainy, it's very rainy. And this is an agriculturally dependent population. When it's rainy, most people are out in their farms. Population density is comparatively low because people are broadly distributed, right? At the end of the rainy season, when the dry season comes, they harvest grain and then tend to come and collectivize grain in towns, villages, and cities, right? And they collectivize grain in these large family compounds. And so populations then go from being broadly distributed to being tightly collected. And that increases contact rates and increases the likelihood of measles outbreaks happening, right? So that association made sense, but what we needed to do was show that it was really happening out there in the world. And so one of the innovations that Nita did, so Nita works on lots of remote sensing, she looked at satellite images of the world at night and specifically looked at serial images, right? These things that you've seen these are composites of many days all stacked up together. What she did was to take that and disaggregate it and made movies of the nighttime lights, particularly in the vicinity of cities and towns in Niger. And maybe this will work. Right? And so she made these movies of nighttime radiation, right? And showed, so these are 1, 2, 3, 4 cities in Niger and 1 city in northern Nigeria. And what she showed is that in the rainy season, when measles transmission is the lowest, these cities are at their smallest because most people are out tending to their farms. But when the dry season comes, the magnitude of those cities grows, right? More people are coming in. There's more radiation in the center of the cities, but also the edges of the cities. What are these sort of seasonal portions of the city on the outside that agriculturalists come and use and only populate during the dry season for grain storage and collectivization, right? So she was able to show remotely that these patterns, independently measured, exactly track the patterns we expect of aggregation that then give rise to high rates of measles transmission. I've been fascinated with the seasonality of measles for years now. It's magnificent. And so we've started looking all around the world to try and understand what is the predictability of measles outbreaks? How regular is it? How well can we predict? Where do we need to go to, again, pre-possession resources? Where do we need to enhance and support surveillance systems to detect outbreaks, right? I spent a lot of my time focused on the continent of Africa because that is the largest single contributor to measles mortality around the world. And what's shown here is a radial diagram with a histogram on it that shows you the incidence of febrile rash. This is all the stuff that could look like measles. In green are the confirmed measles cases, and in this sort of pink color are clinical cases that the kids presenting with fever and rash that could be measles, but they didn't have access to a test, so we don't know for sure, right? And this is the histogram for Niger, where you see lots of cases in this season and very few cases in this season. So if this thing is leaning to one side, that implies strong seasonality. If it's broadly distributed around the year, that implies that there's risk throughout the year, right? And what we found, right, is as we look, and this is all done in conjunction with the World Health Organization, as we look across the area, we see regions like the Western Sahel and Western Africa, where whether you're talking about measles or other sources of febrile rash, things like rubella and parvovirus and other things that give rise to these things, right? Those are all really quite seasonally constrained, right? So they're all happening at one kind of predictable time around the year. But if we broaden out, right, there's some similarity. Neighbors tend to have similar patterns and similar seasonality. But the further we move out, right, the more that regularity starts to break down. And there are definitely parts of the world where that risk is broadly distributed throughout the year. And again, this is, again, critical for understanding both the likelihood and possibility of measles outbreaks, but also the sensitivity and specificity of surveillance systems, right? Because what you're seeing in here, right? There are two things to note, right? One is there's a whole lot of pink, right? And I said pink are the cases that meet the clinical case definition, fever and rash, but they're in places where there isn't access to clinical confirmation or diagnostic tests, or laboratory confirmation or diagnostic tests. So we're not sure if that's a measles case or not. It just meets the definition, and so we have a highly sensitive definition that might raise an alarm. There are lots of areas where there's this blue or purple, right? Those are lab confirmed, not measles, right? And so again, where you have lots of things that could be confounding the surveillance system, right? Then you need to think a little bit more about how we determine and distinguish whether the rise in the syndrome of febrile rash is attributable to measles or not, right? And where we should be targeting and focusing resources, both at the national and the international level, right? Again, many of these countries, all of these dynamics have changed over the 15 or 20 years that I've been doing this, but many of these countries are still heavily dependent on international aid to support these vaccine programs. One of the major supporters and funders of this kind of research to identify risks and prioritization is Gavi, the Alliance for Vaccines, which is a global investment bank that provides grants and loans to countries to improve their vaccination programs. And they, of course, have a vested interest in being as efficient as possible with the distribution of their funds. We've taken some of those ideas further, in a paper led by Matt Graham and Amy Winter in Science in 2019, we looked at trying to characterize the patterns in dynamics that we expect to see in these boom and bust cycles as countries progress along what we call the path to elimination, right? Oftentimes, we might naively think that the path to elimination should be pretty easy. We should be able to measure that in terms of vaccination. If you vaccinate more, you're going to have less measles, right? And all you need to do is get to a high level of vaccination, and you'll eliminate measles. That's in fact the basis of a lot of the WHO guidance, right? 95% of the population vaccinated with 2 doses of measles. If you get to that, measles is going to be gone, and that's what you need to go. That's what the WHO has set as guidelines, right? Unfortunately, there's not a good way to measure progression up to that point, right? And what we're seeing is that there are lots of places in the world that have gotten to high levels of measles vaccination, at least reported, where they still see persistent measles, right? That can be because of regional reintroduction or all kinds of other patterns that could arise, right? So what we were looking for was a dynamical signature that might tell us, regardless of vaccination, independently from the time series, can we tell a place that is close to elimination or far from elimination, so we can, again, try and identify ways of prioritizing things, right? What they did is they found that you could very easily map countries out in this natural progression of incidence versus variation, right? That fluctuation and unpredictability or unpredictability that I've been fascinated with. And they found that as countries progress and over time, right? These are red countries are far from elimination and blue countries are close to elimination. We tend to see as incidence drops, and as incidence drops, the coefficient of variation increases, right? So even relative to the mean, the noise gets bigger, right? Right up until some point where that turns around, and we're right at the point where you're right close to elimination, right? You stay at low incidence, but you go to regularity, right? And this now gave us a set of dynamical signatures that we can look for in time series to try and identify where countries are in their progression to elimination. So this is what Matt and Amy called the canonical path to elimination. And this gives us a new way of demarcating and prioritizing countries that is separate from vaccination alone, right? And it necessarily includes things like the performance of the vaccination program, not just how many vaccines they say they're distributing, but are they being distributed effectively? Are they being distributed equitably? Many countries are distributing lots of vaccination, but still, because of all kinds of structural barriers and challenges, leaving subpopulations highly at risk. What they then did was said, we could take that path, that curvy path, and map it out with mile markers and turn that into an x-axis. And we can look across that x-axis whether or not there are other important and relevant epidemiological phenomena that are going to vary in a predictable way along that axis, right? And absolutely, we see that. So as you move along this axis, I'm sorry for the projection quality, right? The mean age of cases tends to go up, right? And so the cases of kids that are getting measles tends to go up. And so where we're looking for measles cases should change the further we are around that path. That makes sense as measles becomes rarer and more regular. It takes longer for each child to be exposed to measles from the time of birth to when they first get infected. And so on average, they will be older and the distribution of ages will be longer, right? The percent of cases that are among young kids or old kids is going to change in predictable ways. The percentage of the susceptible population that is in old kids and young kids will change in predictable ways. And so we can now use that to guide the planning of vaccine campaigns and targeting. Where can you get the most bang for your buck in the targeting of vaccination? Is each dose of vaccine targeted to a 5-year-old or a 15-year-old likely to find its way into a susceptible arm? Right? That's oftentimes the thing we're doing. Many vaccine efforts and these sort of community-based push strategies for vaccine are necessarily redundant. You're going out there and you're vaccinating kids that have previously been vaccinated or maybe previously been infected. That's fine. There's nothing wrong with the redundancy. But if we can minimize the redundancy by smart and thoughtful targeting, right, then we can make those programs more efficient and we can save that money, and that money can then be directed to other health issues. Right? I'm looking at the time.
3 more minutes.
Yeah, 3 more minutes, right? I did want to at least mention this though, and because I think this is again one of the critical things is that, that predictable unpredictability, we can use that to some extent, right? But we're oftentimes stumbling on the path to elimination. There are individual events that kind of knock us off that path, right? We got involved looking at the case study of the Ebola outbreak in 2014 to 2016, not because of its impact on Ebola, but because of its impact on routine vaccination systems, right? Trying to quantify what the magnitude of risk of that disruption was and how fast we had to try and replenish vaccine stores and improve vaccination programs, right? And what we found was that the potential for secondary mortality associated with the reduction in measles vaccination, right, was in fact dramatically greater than the mortality associated with Ebola on its own, right? So Ebola was going to have this long legacy because of the disruption of primary preventive services. And so we work with the Gates Foundation and the World Health Organization and Gavi to come up with a way of quantifying that and use that as motivation for changes in investment. We've done the same thing in response to the disruptions in vaccination programs around the world because of the COVID. Right? All of which started with a phone call that I answered in an office over there in ASI when I was a graduate student in the entomology program, in the entomology department. And so with that, now I probably have like 30 seconds left. I'm going to stop. And if anybody wants to stick around and ask questions, I'd be happy to answer.
I have 2 minutes. So thank you, Matt, for a fantastic talk. Sticking to tradition, we'd like to take the first question from a trainee.
Thanks for such a great talk. What do you think the biggest challenge is like in the maybe not post-COVID, but in the mid to post-COVID world, like what is the challenge moving forward with pandemics?
Pandemics.
Like from the $1 million or the million-mile view up.
Yeah. It's gonna be a cynical answer, but I'm very concerned that we're just gonna do exactly what we've done for every other pandemic before. Every pandemic that happens, we throw huge amounts of dollars into trying to come up with systems that can predict the thing that just happened. And what we do not do is take that same amount of money and put it into systems that at least at base address routine problems, public health challenges, and maybe have an add-on benefit of also providing some service for the pandemic. I didn't use this figure here, but I've been using this figure a lot. Bill Gates wrote an op-ed in the New York Times in March of this year, saying that we need a pandemic fire brigade, right? A system that will be around, watching for fires, waiting, and as soon as the fire happens, they'll run out there and they'll put it out, right? Now, I don't know about, I know that Bill Gates doesn't know how much a gallon of milk costs. I'm pretty sure Bill Gates also doesn't know what the fire department does, right? Because most of our interactions with the fire department are not putting out fires. Fire department is out there guiding traffic. When there's an accident, they're cutting down tree limbs, they're laying on power lines. So they're doing things to prevent pandemics. They're doing things to prevent outbreaks, to prevent fires, right? But they're also doing routine services, right? Directing traffic, helping with, crowd control at large events, right? They're showing community and societal benefit on a day-to-day basis. And because of that, right, their buildings get updated, their trucks get renewed, there's gas in the tank. And so because they're showing routine day-to-day benefit, they are there when the pandemic happens. And I think the most important thing, the most important criterion for a pandemic response service is that they beat it, not how they're, right? And so I think our focus on cool, exciting digital health and mining Twitter and doing all this stuff that I think has been the focus of a lot of the discussion over the last couple of years, right? I think that's a distraction because we did it after Ebola, we did it after H1N1, we did it after SARS-1, right? And the money for that dried up within 6 to 12 months. And those systems didn't persist, right? And now we're back in this discussion of ramping them back up, right? So I think the biggest challenge is not even just maintaining attention, it's taking attention away from that stuff and putting attention into routine services, right? And because again, if we have routine services, we will then see the rare things, right? If you build up the distribution of normal and you can tell normal really well, you know how many cases of this and that you expect to see from day to day. When the weird things happen, you're going to see the weird thing right away, and you're going to know it's weird, and you'll respond because we know something's going to happen. We just don't know what it is. We can't plan the drugs for the next pandemic. So we don't know what the next pandemic should be caused by, right? So this idea of trying to target specific pandemic threats and risks, I think that's a distraction, and it has a huge opportunity cost that's taking things away from primary health.
Thanks.
You're asking trainees, so I just consider myself a 47-year internal medicine resident, so I'm still a trainee. But anyway, it was a wonderful talk, Matt, and I don't have a specific question, but just, I wanted to say I'm visiting from Stanford. Just what a wonderful institution that you have here at Penn State, and just what great work you're doing. Thanks.
Thank you.
I do have let me see, anyone else has a question? Actually, it's 12:03. If you need to run, feel free to run. We're gonna stick around for a few more minutes. Zach, you have a question?
Go ahead.
No, mine is long.
Nicole.
I'll catch you later.
So what work is being done to model like microbiome variation and how that's impacting these trends?
I have the foggiest clue. I really don't. I thought there was a way I was going to sneak this in. I don't know, but my first exposure to microbiome was first through plant pathology, right? And the sort of the phyllosphere and the role that plays in preventing the colonization of pathogenic foreign bacteria. And then in work that Eric Harville did here at Penn State on pertussis, looking at the disruption of the respiratory microbiome following flu infection, and what that did is increase the susceptibility to invasion by pertussis and parapet. I think I'm getting that all right. And you'll remember maybe if I'm getting that sort of right. Right? And so that I thought was really fantastic. And that to me is this idea of the microbiome as the sort of one of the pillars of the immune system and the immune response. We have mechanisms for building models about variability and susceptibility, right? It's just that we talk about it in terms of broad scale phenomenon, right? I think we can harness that. We can't represent the complexity of the microbiome, but if you can coalesce some characterization of the microbiome into a phenotypic description of, its role as a barrier to infection or a mediator of susceptibility, then I think then it's really natural to translate that, that phenotypic summary into many of the mathematical models that we already have for dealing with heterogeneity and susceptibility.
Yeah, one thing I'm thinking about, it's really naive, I think, is, if we're developing vaccines against highly infectious diseases, and these are our major intervention strategies, are we going to be deploying that for chronic diseases that are also associated with microbiome agents? For example, cancer is now linked to the presence of certain bacteria inside the colon. So should we be thinking about vaccines that prevent those particular cancer microbes from ever colonizing us and preventing chronic diseases through that kind of concept?
That's fascinating. So so the conventional model for vaccine has been sort of a 1-for-1, right? There is a unitary source of harm, and the vaccine. The beauty of vaccines is they are specifically targeted against that one thing.
Yeah.
Right.
Those make complete sense,
yeah,
and this
right.
is really
Yeah.
definitely around the corner.
Yeah.
When we think about your work in the context of the microbiome's work, and whether in any of our systems where we find causal or associated microbial links, will vaccines help us against preventing those chronic diseses?
Yeah. So I have no idea. I can give you some feedback on different things. So I talked to I was at Penn early in the year. I was talking to Drew Weissman, who's one of the developers of mRNA technology. He's the guy that said, why do you encase it in fat? And I mean, he's super bullish on mRNA technology, and he's like, I can make a vaccine against anything. Give me anything, and I can target it. Right. There's a huge potential for proliferation there.
Yeah.
I will tell you from my experience, I am very cautious. I'm enormously conservative about vaccination as an intervention. The reason being is that it is one of the rare medical interventions where we take a healthy person and we put something into them, right? And because of just like, I did that project where we had to show that there would have been a bigger outbreak if we hadn't vaccinated, right? We have to do that at the individual level. We have to say you would have gotten sick if we hadn't vaccinated you. And that's a hard thing for most people to process. It's really, it's possible that we can show biologically that it works. But I think there's a real challenge in taking that to market and getting it adopted and used by people and showing that benefit. And we have so many examples of failures in vaccine rollout and vaccine messaging, or just mistakes or bad things that happen because we didn't expect them, right? That have then had knock-on consequences for other aspects of the vaccine system. And so that's why I'm super conservative about even the speculation about what we could do with vaccines, right? The Dengvaxia vaccine rollout in Philippines, it was a vaccine against dengue fever. Dengue has this complicated immune interaction where subsequent infections with different strains can lead to an amplification of the disease response, a strong inflammatory response called antibody-dependent enhancement. And because there were so many people that were vaccinated that had never had a primary exposure to dengue, right? They were vaccinated. The vaccine was their first exposure. And then there was enough circulating dengue in the Philippines that they then got infected by circulating dengue and had these really severe reactions. And there was an increase in the rate of dengue hemorrhagic fever, the really bad outcome.
Yeah.
That's horrible in and of itself. But that has for years now suppressed the routine childhood vaccination program, and measles vaccination rates in Philippines are through the floor because of the knock-on effects of that, right? So again, I'm super conservative with respect to vaccine because it's not, it's not like a lot of the drugs we have where you can talk about them one at a time, right? This drug, you treat somebody, they get better, and then they say it works, right? Vaccines, you have to think about the potential consequences and indirect effects of speculation. And what that might mean and about sort of adoption. Yeah.
Right, that's, let's think, Matt.